Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
You're listening to Healthcare Matters, the podcast that breaks down the healthcare policy and economic issues that matter most to patients. With us is Robert Popovian from Washington, D.C. He's a pharmacist, an economist, and Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me is my good friend and co-host, Amelia Degrassi, Associate Director of Operations and Strategy at the Global Healthy Living Foundation. Tuning in from New York. Angela, how are you holding up these days?
I'm doing well, thank you, Robert. And I'm excited for today's topic because it's pretty outrageous once you dig into it. So just a warning to our listeners, you may feel a little outraged after listening today. We'll be talking about 340B drug discount program. This program sounds really great, yet has some real consequences for patients. Right, Robert?
Absolutely. And it's a very technical program, and most patients don't understand. Most healthcare professionals actually don't understand it. But this is why we started Healthcare Matters, right? To make sure that we explain these type of things and how a federal program, which was developed in the early 90s, has a direct connection to drug affordability, hospital finances, charity care, affects patients, especially vulnerable patients who actually benefit. And this program was created for.
Which sounds really incredible and important and valuable. So a lot of people who are on prescription medications who may benefit from this program might not have ever heard of 340B, but may be receiving care at a 340B hospital. And they might not know the hospital is buying certain outpatient drugs at a steep discount. Can you tell us more about that?
Well, that's a key point, right? So nobody's claiming that the 340B program should not exist. It's a valuable program. But the question is whether the benefits is actually reaching the patients directly. If a hospital is receiving significant discounts, as you mentioned, for medicines by pharma companies, the patient should be able to ask, what is the benefit to me as an individual? And how is this helping me lower my drug costs and my out-of-pocket costs? And ask for financial assistance from these institutions. But that's the key here. The program is a great program, but are patients benefiting from it directly?
Totally, yes. So the money's flowing. Is it going to the right spot is the question. So today we're going to walk through what 340B is, why it was created, what some of the concerns are, and then we're going to talk about a recent study you co-authored looking at 340B hospitals and charity care.
And this is super important, why this should matter to patients.
All right, let's get into it. Robert, let's start with the basics. For people who have never heard of 340B before, what is the program? Tell us why it was created, and how is this supposed to help patients?
The 340B program was created or came about in the early 1990s. I personally was doing my residency during that time in a hospital that desperately needed this program because I would say 90% of the people walking in were uninsured at an institution I was training at. So this program was needed, and it was created to really help these safety net providers, these hospitals, to buy drugs at a much lower price and then be able to stretch their limited resources by helping patients. So the hospital would buy the program at a discounted level and then would charge a higher level for the insurer or the Medicare program and then keep the difference between the discounted price and the selling price that they were reimbursed for, and then use it to provide care for patients who were uninsured or underserved or underinsured. It's a fabulous program that was instituted in the early 1990s.
Wow. Okay. So that sounds like it would be super helpful and could potentially serve a lot of people. So let's make this practical. Why should a patient care whether their hospital participates in 340B?
The patient should care because if they are aware that the hospital is participating in the 340B program, that means the hospital is purchasing outpatient medicines at a significant discount. That does not mean that the patient automatically receives that discount, but it does mean that the hospital should be informing the patient, and the patient should be able to ask if that discount is available to them. Patients often don't know to ask these questions, and that's why there's a problem with the program that we need more transparency and accountability for these hospitals to disclose this to the patients, because not every patient is going to be able to afford their medicines. And remember, these are for outpatient medicines that the patients do pay out of pocket.
Right. So it sounds like the program functions, just maybe not how it was intended. So you said the purpose of 340B is reasonable and helpful, but there are concerns with how the program works today. So what are the major pitfalls? Walk us through this from a patient and policy standpoint.
So the program has grown significantly. Probably this year, in fact, it will be the largest federal drug program, which is not a true federal drug program because it's fully funded by the biopharmaceutical companies. But what it lacks, as much as the growth has happened, the accountability and the transparency has not kept pace. So there's several things that can be fixed. First, there's no transparency. We don't know how much of these savings the hospital receives for the 340B program and how those savings are used because there's no need for disclosure by the hospital. Second, there's no clear federal requirement that the hospitals pass the discount directly to the patient. Third, hospitals qualify for the program, but that does not necessarily mean every patient receiving 340B is a low-income or uninsured patient. In fact, to qualify for the program, the bar can be as low as not having any uninsured. They could be classified as a rural referral center, for example. And then the fourth is that there's not enough standardization around charity care. Charity care is a good parameter to distinguish how hospitals are benefiting from this program and how they're putting money back into the community. So even though the hospital's benefiting financially from 340B, they don't necessarily need to put the money back in form of charity care into the community. And that's a good sort of parameter and a surrogate to measure whether they're doing that or not. So there's not enough standardization about charity care taking place.
Okay, so lots of challenges there. I feel those points you just made could be a whole other episode, but let's pivot and talk about your study. Tell us, why did you and your co-authors decide to look specifically at 340B hospitals, charity care, and uncompensated care?
Well, the simple question we wanted to ask is, are 340B hospitals on average providing more direct financial assistance in form of charity care than non-340B hospitals? Remember, Angela, in the world of hospitals, not every hospital is a non-for-profit and not every hospital is a 340B hospital. There's a significant number of hospitals that are for-profit hospitals and there are also non-340B because for you to qualify to become a 340B hospital as a covered entity, you have to be non-for-profit. So the simple question we wanted to ask is that institutions that are not 340B and are most cases for-profit institutions, are they doing equally as much or less charity care and uncompensated care than 340B institutions who are receiving this windfall of drugs that are discounted from the biopharma companies? Because remember, the justification of the program is that it should help these safety net hospitals to help vulnerable patients. And this study focused on hospitals specifically because hospitals are where many of the large financial questions come around and are concentrated. Remember, in the world of 340B, it's not just hospitals, right? It's these clinics, the federally qualified health clinics, these Ryan White clinics that also qualify for 340B. But from a revenue standpoint of how much is gained through the 340B program, the clinics are a minuscule part of it. And in addition, those clinics already have a lot of regulatory stuff on them with regards to reporting and requirements and how much money they put back into the community, while hospitals lack all of those.
Wow. Okay. So that's super interesting. And I am looking forward to reading that study. Can we post that in our show notes?
Absolutely. It's in a pre-publication server. We're very transparent. In fact, we want to hear from people who read the study and provide us feedback. And we did get some feedback recently, and we've made some adjustments to it. The data hasn't changed from the feedback. All we did is basically change the rhetoric in the paper. But at the end of the day, absolutely, it's available for anybody to be able to see it. And we will put it in the show notes.
Okay, that sounds good. Can you walk us through the study in plain language? What did you compare and what did you find?
So we compared 340B hospitals to non-340B hospitals, and we looked at certain measures. We looked at charity care, uncompensated care, and Medicaid admission percentage. And also specifically charity care for uninsured. We have all of this data through the RAND Corporation. RAND gets the data from CMS, and what they do is they clean up the data and then they sell it to institutions like the one I published it under the Pioneer Institute. So we bought the data from RAND Corporation, but it's really CMS data, first of all, and it comes directly from the hospitals. So charity care is not a perfect measure, but it is one of the clearest ways to evaluate whether hospitals are providing direct financial assistance for patients who cannot afford it. And the main finding we found is that 340B hospitals on average provide less charity care than non-340B hospitals. Remember, these non-340B hospitals don't get this windfall of these discounts. That is important because these hospitals are receiving these discounts and they're not putting enough money back into the community. And the same thing applies to charity care for uninsured. And in fact, they provide less as a percentage of their operating expenses toward uncompensated or unreimbursed care, these 340B hospitals, than the non-340B hospitals. The only measure that we found that the 340B hospitals do better is a percentage of their admissions with regards to Medicaid is higher than the non-340B hospitals. I think it's in the 20 plus percentile versus in the 17, 18 percentile for the non-340B hospitals. But otherwise, these for-profit institutions that don't have these windfalls and don't have the tax breaks of being a non-for-profit actually do more for your community in form of charity care and uncompensated care, both for overall charity care and for charity care for uninsured.
Okay, interesting. So, from the patient perspective, what do we take away from this? And what should patients or caregivers ask if they are receiving care at a 340B hospital? I'm super curious what action items are here.
So remember what I told you. The statute or the program doesn't require that the discount is directly passed on to the patient. The way it works is that they buy it at a discount level. These institutions, they charge Medicare and private insurance a much higher rate because of the normal price of the medicine, and they keep the difference. And the whole quote unquote reasoning is that then they put it back into the community and they take care of uninsured and underserved patients. Well, for one thing, patients should know if they're in a 340B hospital and if they do need help with their outpatient costs for their drugs, those discounts should be passed on to them at the point of service. So that's one of the things that patients should be informed that it's at the 340B hospital, that they have this discounted drugs that they receive from biopharma companies. And if a patient cannot afford their drugs, that those discounts should apply to their out-of-pocket costs. And that's one of the things I would say that the patients should do. In fact, it's not even the patient should be asking. That should be disclosed to them upfront by the hospital that they're attending or by the clinic or anybody else who's receiving these discounts.
I couldn't agree more. So let's talk about solutions. Based on the study and your broader work on this issue, which I know you know a ton about this, what reforms do you recommend?
So first and foremost, we've said this repeatedly, if you require patient notification, patients should be told that they're receiving care at a 340B hospital or institution and should be informed that the hospital received this discounted drugs through the program, number one. So if they require those discounts to be passed on to them, they should mandate that they are passed on to them. Second, there has to be a clear pathway for them to request for help. If a hospital receives the discount, the patient should be able to ask for it and receive it in a very transparent manner from the hospital system. Third, require more transparent reporting. Hospitals should report how much of those 340B revenues are they getting and how much of it are they putting towards charity care, uncompensated care, and medication assistance. So in other words, not only overall from their percentage of charity care that they provide, but how much of that drug discount program gained from the revenue from the 340B are they truly putting back in charity care, uncompensated care. And fourth, consider minimum charity care or patient assistance program for hospitals. There is no requirement, there is no guidance from the federal government that a minimum percentage should go back into the community. Fifth, make sure that the rules are standardized. Right now, federal definition of charity care exists, but there's a great deal of leeway by hospitals to be able to redefine what charity care is. For example, if a hospital defines charity care as a patient education program or leaving pamphlets out or doing a hypertension screening, that's not patient care. They should be able to use that money for actual providing patient care at the point of service. Finally, every hospital type that is covered entity and qualify for 340B discount, the eligibility should be tied to some hospital disproportionate share adjustment percentage So it should not just be the disproportionate share hospitals that have that requirement. It should be all hospitals. Because remember, I told you there's several categories of hospitals that qualify for 340B. It's not just the DSH hospitals, the disproportionate share hospitals. There's the critical access hospitals, there's rural referral centers, community hospitals. All of them should be required to have a minimum requirement for disproportionate share admission of patients in their institutions. Look, I'm not saying we need to eliminate the 340B program, but I'm saying that reform the program so it actually benefits patients and it's not some black box where all these savings comes into the institution and there's no accountability of how those savings are utilized for patient care.
Okay, that is so much to think about. And before we wrap up, what is the one takeaway you want patients, caregivers, and healthcare professionals to remember from this conversation?
The main takeaway here is that the 340B was created to help vulnerable patients, but patients are not often told when a hospital receives these discounts and they're not guaranteed to benefit directly from them. So the patient should be informed, hospitals should be transparent, and if a 340B hospital receives the discount in medicine, patients should have a clear pathway to be able to get them. Remember, 340B hospitals get these huge discounts, and they're not doing as much charity care as non-340B hospitals. Step back and think about it. For-profit institutions who pay taxes, federal, local, and state income taxes, are actually doing more charity care than non-for-profit institutions who have a windfall coming to them in form of 340B program. We are talking about they're doing less. They're not even doing equally well. This is important, and this is not about eliminating the 340B program. It is making sure that the program works for people that was intended to serve, and the institutions who receive these windfalls are actually providing charity care, uncompensated care for their populations more than for-profit institutions that are currently doing much better than them.
Yes, and I hope by shining a light on this that it does help with progress on reform. This was so insightful. Thanks, Robert, and thank you all for listening. That wraps up today's episode of Healthcare Matters. If you liked this episode, like and subscribe, and be sure to check out the rest of the GHLF podcast network on the Creaky Joints channel.
If you have any questions, thoughts, suggestions, we're always listening. Our ears are burning. Angela and I are always interested in your thoughts and comments. We'll bring you on if you have a great idea. So please email us at podcast@ghlf.org. We would love to hear from you.
He's Robert Popovian.
She's Angela Degrassi. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.